Good morning. This is Dr. Eric Bricker, and thank you for watching A Healthcare Z. Today's training session is on success stories in healthcare finance. Now, as always, I highly encourage all of you to put your questions and comments in the comment section on either LinkedIn or YouTube, where we're broadcasting this. And just to do a quick check, if you could just let me know if you can see me and hear me okay, and put that in the comments so I can see that. And then throughout the presentation, as you leave comments and questions, I'll be able to see them. And then I will pause throughout the presentation to answer your questions as we go through. So thank you so much for joining. And the reason why I wanted to talk about success stories in healthcare finance is because our previous training session was about the 30 examples of deception in healthcare. And I was like getting like depressed after giving this presentation. I'm like, oh, this is horrible. And it's not all doom and gloom, right? There's the yin and the yang, right? So it's not all bad. There's also successes as well. And we need to use these successes as examples and as ways to benchmark and borrow ideas for us to use in our own endeavors to improve healthcare in our own unique ways that we're all doing that here. So thank you for coming along for that journey. Now, brief background about myself. Many of you are familiar with me, but for those of you who are new and are not, so I'm an internist, but before I went to medical school, I actually was a hospital finance consultant back in the 90s because doctors and hospitals hired consulting firms to show them how to get paid. So it was a fantastic experience. Did that at the University of Kansas Medical Center, Cleveland Clinic, Yale Associated Hospital, and then went on to get my medical degree from the University of Illinois at Chicago, and then did my residency at Johns Hopkins in Baltimore in internal medicine. And then I actually moved to the Dallas-Fort Worth area after my residency. My wife and I were recently married, and I got a job working as a hospitalist at one of the Baylor's, one of the big hospital systems down here in DFW. And I got a job as a hospitalist. And then I also, while I was actually in residency, I actually started a healthcare navigation firm called Compass Professional Health Services, where I was the chief medical officer, along with my two other co-founders, Scott and Cliff, because we had seen so much confusion and frustration on the part of patients. And Cliff had a technology background, and Scott actually used to be the EVP of finance for a major hospital system. And so between my sort of bedside understanding of the complexity and then Scott's understanding of the complexity on the billing side for the hospitals, we knew that we couldn't, quote unquote, fix the entire healthcare system, but we could kind of fix it one person at a time through our navigation services. You can think of it instead of cutting down the jungle and paving it over, we were just like really good guides. We could totally get you through the jungle because we knew how to do it. And so we had, technology and people, these healthcare navigators, we called them health pros, that would help you would buy our service through your job. And we had 2,000 employer clients. We grew it to about 1.8 million people that we did this for across the country. We sold that company to Alight Solutions, which was a 10,000 employee spin out of Aon back in 2018. And I worked with a lot of employers really for 11 years. I was meeting with HR, broker, benefit consultant, CFO, CEO, and talking with them about how healthcare really works. And there was still a tremendous misunderstanding in terms of what was driving their escalating cost and variable quality for their employees and really low levels of satisfaction with their employee benefits. And I'm like, okay, well, I'm just going to make these videos because I'm not really beholden to anybody. And I can just, do my best to shoot people straight to kind of educate them around the U.S. healthcare system. So that's the A Healthcare Z videos. I've got a YouTube channel. Obviously, you see them on LinkedIn as well. And then recently, I was asked to become the medical director for SimplePay Health, which is an alternative health plan that I'm actually going to talk about more as one of the success stories. So I'm going to, the framework that we're going to talk about success within is this idea of exit, voice, and loyalty. So this is a book by a gentleman by the name of Albert Hirschman. It's written in 1970. I just have to very briefly tell you the story of Albert Hirschman because he's a fascinating person. So he was born like in 1915 in Germany. He was a German Jew, and then he went to France for his education and became trained as an economist. And then when World War II broke out and Nazi Germany then occupied France, he actually helped French artists escape to Spain over the Pyrenees Mountains. And oh, by the way, he even fought in he volunteered to be a part of the Spanish Civil War even before World War II. And so he eventually was able to actually get out of France and come to America, or sort of early on, 1941 in World War II. And he was, incredibly smart, intellectual, and he actually helped then after World War II with the rebuilding effort in Europe. So he worked for the US government, spent gobs of time in Europe helping to rebuild after the war, and then went on to become an economics professor at Yale and then Columbia and then Harvard, and ended up dying at the age of 97. He was married for over 70 years. I mean, if anything, that probably was one of his greatest accomplishments. I mean, that's just awesome. So he wrote, as an economist, he wrote this, he was sort of, he did a lot of behavioral economics, sort of before it was called behavioral economics. And he wrote this sort of very famous book in 1970 called Exit versus Voice and Loyalty, where he says that members of an organization really have three options when it comes to change. And they can either exit the organization, and that could be a company, so they could quit and leave, or it could also be a country. They could emigrate. They could just leave the country. I don't like the way this country's going, so I'm just going to leave. Versus voice, which is speaking up or protest, talking to management if you're within a company, et cetera, making your changes and your wishes known. Versus loyalty, which is basically just to keep quiet and go along. So he essentially said you have three choices. Everyone has three choices. And really, in working for change, there's actually a synergistic relationship between exit and voice. So we're going to talk about the combination of exit and voice and how they were used with each one of these healthcare finance examples. So the first one, I'm going to go into more detail around the company that I founded, Compass Professional Health Services, and our successes that we had in healthcare navigation. And this is not meant to be some sort of pat on your back sort of thing. I mean, at the end of the day, we were just super fortunate to be able, we were kind of in the right place at the right time to be able to help these folks. And I just wanted to show you kind of how the voice versus exit manifested itself at Compass. So Compass, as I mentioned, it was tools and support for healthcare consumers. It took the form of a personal healthcare concierge, where we call them a health pro, and you would interact with your health pro by phone or by email. And we had an app as well. You could do some self-service looking up things as well. And you would get your Compass navigation service through your job. And so you'd have your medical, your dental, your vision insurance, and then you would have your Compass Health Pro to help you navigate all those. And our Compass Health Pros were basically administrative experts. We didn't do any clinical decision making. I mean, that was between the doctor and the patient. But for all the morass and quagmire of healthcare, that's what we were experts in, and we would help our members with. So the specific services that we provided were one, and this is kind of in priority of the most frequent services we provided for people. Number one, doctor recommendations. People are like, I've got X issue. Who should I go see? And at a very basic level, a lot of times if you talk to doctors, one of the basic things that their patients need is they're like, who's good? I don't even know what type of doctor to go to for this. It's I got this. I need it addressed because there's a gazillion ologists. I mean, I've made videos about it. There's literally 58 different ologists between the dermatologist, the gastroenterologist, the otolaryngologist, the cardiologist, the neurologist. You get the point. Your average person shouldn't even be expected to be able to navigate all of those ologists. So that at a very basic level. And it's okay, Like we would even screen them for basic things like appointment availability. Because if you're trying to find an ologist on your own, especially like a dermatologist, like good luck. Like you call around 6 month first appointment. Next one, 9 months first appointment. Next one, 3 months first appointment. Like I want to go like next week. Like, is there any way that somebody could tell me who's available in my area like next week? That would be helpful. So we actually screened all the docs for their appointment availability. And that was just at a very pragmatic level. That was super helpful in terms of getting people in the door. Number two was, of course, the bills constantly got screwed up. And of course, anytime you got a bill, of course, it was coming from the doctor's office or the hospital, you call up the hospital or doctor's office, like, well, it's not our fault, it's the insurance company's fault. And then you call up the insurance company, like, that's not our fault, it's the doctor's office or the hospital's fault. And so then you were stuck. So we were basically sort of like the ombudsman. We were like, we're going to take your billing problem and we're going to own it. And we're going to figure out where the error occurred. And sometimes it was with the doc in the hospital. Sometimes it was with the insurance company. I mean, believe me, there's a gazillion ways for a bill to get screwed up. And so because we just literally resolved problem bills all day long, we developed a lot of expertise and efficiency around that your typical person would never be able to do. Okay. And we just answered insurance questions for people. And it was like, because people did not understand how their health insurance worked. And that really tied to the doctor recommendations, because people oftentimes were asking questions like, well, what's my, how does my deductible work? Or I thought I met my deductible. And typically they weren't just asking those questions because they were curious on a Friday morning. It was because they were like, because I need to go see some sort of ologist. So the insurance questions, like 9 times out of 10, like tied into some other sort of service that we were going to do for them, like finding them a doctor. Now, they didn't call us expressly looking for a doctor, but that's really the underlying need that they had. So it was very important to have a sort of cast a broad net of pain points that we could address for healthcare consumers. And then, of course, since we started in 2007, what else began in 2007? Well, people started having these consumer-directed health plans with higher deductibles and HSA plans, and the copays went away. People were like, what's the price of stuff? So we literally had a database across the country of all the allowed amounts by carrier for all the docs in the hospital. So we could actually give people pricing information in advance. And we had their plan design so we could say, okay, well, for your deductible and your co-insurance or what have you, this is what it would translate into for your out-of-pocket cost. So we were doing price transparency in 2007. And so employers really hired us to be the adjunct support service and tool to go along with their consumer-directed health plans. They're like, hey, we're putting in one of these HSA plans. And like, it's complicated, but we're going to give you Compass to kind of hold your hand through this new type of insurance that you're going to have. Of course, so number 5 with prescriptions, of course, prescriptions are hugely expensive, and we would really give them a lot of times there were generic alternatives for the brand name medication that they were being prescribed, or it might even be in the same category. So the big deal back in the 2010 was Lipitor. It was branded, hugely expensive, $300 to $400 a month. And at that time, there was no generic Lipitor, but there were lots of other generic statin medications. So like Zocor had become generic. It was generic Simvastatin. And you could literally get Simvastatin for like $4 or $5 a month versus the $400 Lipitor. And so there, our health pros actually worked because you need a new prescription. Our health pros actually communicated with the doctor's office, and we actually had them call in a new prescription for the person. So it wasn't necessarily like pharmacy shopping, like going from CVS to Walgreens or whatever. Like that wasn't really where the money saving was for the prescriptions. It was in those what are called therapeutic alternatives for the expensive brand name medications. Okay. Now, we also did gobs of open enrollment support, right? So people are like, okay, well, it would be helpful if I could kind of talk about my own personal medical situation as it comes to these particular plan design choices. And like, could you kind of help me think through that? And so that was hugely helpful for people, because just because you have like 3 plan choices doesn't mean people are able to understand how those plan choices would affect them and their own family's personal medical situation. So we held their hand through that. Because we were talking to the employees so much, it was a great way to tie in their other vendors. Oh, by the way, did you know that you had a vendor that helped you for this, or you had a weight loss program that helped you for that, or you could get, $500 in money on your HSA account if you did these things. So it was a great way to then, sort of, tie in those other benefits that we had. And we had a whole software system. We built our own software system to basically be like a CRM, where by employer we could load in the specific plans or offerings that each employer had, so that we knew that if you called in from Southwest Airlines or T-Mobile or McDonald's or what have you, that, these were the specific programs that you had. And so we knew how to, healthy pregnancy program, et cetera. Like I said, we even scheduled the appointments for you. At the end of the day, like, phone trees were incredibly complicated. We would even move medical records around. Anyone ever try to move medical records on this call? Man, woo! Moving medical records is like moving heaven and earth, right? But we had we had an entire department that was dedicated to like doing that administrative stuff. So we could do it much more effectively and efficiently than if people were trying to do it on their own. So anyway, let me give you the specific examples. Okay, here's a success. You're like, okay, fine. These are true stories. Okay, now we had a member in Florida who was like the 20-year-old daughter of the employee of a municipality. It was a very large county, big self-funded employer in Florida. And so this 20-year-old daughter was still on the plan. She went to community college and she had a part-time job, and she had a condition called gastroparesis, where her stomach didn't move the food along. It didn't empty into her small intestine. So the food would get backed up. And when that happens, you get nauseous. You as you can imagine, you throw up a lot and you lose weight. And it's incredibly painful because your stomach gets really distended. And when your stomach gets distended, it's very painful. So she had this constant abdominal pain. It's like a miserable existence. And she had a local gastroenterologist that she had been seen for this. And he had her on like 12 medications. And this had been going on for like 3 years, and it wasn't getting any better. And she had been to the ER like 8 or 9 times. She'd been like hospitalized like 3 or 4 times. And it was really affecting the entire family. She had to drop out of college. She had to quit her job. I mean, it was a disaster. And so her dad initially contacted us, and then we worked with this young woman. And it turned out that there's a Mayo Clinic in Jacksonville, Florida, and the Mayo Clinic in Jacksonville, Florida specifically has a gastroparesis outpatient program where you go and, you have to like stay in a local hotel, but you see their multidisciplinary gastroparesis team like every day for 6 weeks. And it's not only a gastroenterologist, but it's also a pain management doctor, and it's also a psychologist and a psychiatrist as well, because you're outside of your nervous system, your digestive system actually has the second highest concentration of neurons or nerves in your body. And so your thoughts and your emotion and your nervous system actually has a huge impact on your digestive tract. And so between or among those 3 specialists, and over the course of that 6 weeks, they were able to get her from like the 12 medications literally down to 2. And her symptoms dramatically improved. And she was able to go back home, and she was able to restart junior college, and she was able to go back to her job. And so the punchline is that our health pros would actually travel for like open enrollment meetings or like wellness, vendor fairs or whatever to the employer. So one of our health pro, because we assigned health pros so that they had a relationship, so you had the same person working with you. And this health pro went to the county wellness fair, and the father was there too. And he came up and he was like literally almost in tears. And he told the health pro this story about his family and his daughter. And he said, not only has this changed my daughter's life, but it's changed our entire family, because when you have a sick member of your family, like it affects the entire family unit. So it dramatically changed the husband and the wife and the other siblings' lives as well. So, I mean, just huge success personally for that woman and her family. Okay, next up. So anyway, long story short, too, the punchline there is there are absolutely pockets of excellence within American healthcare. I mean, arguably, what she got in Jacksonville, she might have not been able to get like anywhere else in the world. I mean, it was awesome. So the point is that there are absolutely pockets of some of the best care you can possibly imagine. We're incredibly fortunate in this country to be able to have these pockets. The challenge is getting to them and getting the care, and then not having the billing be a disaster and financial ruin afterwards. And guess what? That's possible. It's totally possible. Okay, next up. Ophthalmology CPT code. So just very briefly, there's this thing called medical policy, and medical policy means that you have, it's an actual term. It means you have health insurance, and the medical policy is all the buts. And all the buts are things like, or specifically, a lot of times they're coding related, which is like, okay, if you have this particular diagnosis code, you can only bill for these particular CPT codes with that diagnosis code. And that's exactly what happened in this ophthalmologic example, where a member of ours had an in-office laser retina treatment by the ophthalmologist, but that laser retina treatment is only approved for certain diagnosis codes. It's not, and by approved, I mean approved by the insurance company for payment, not clinically approved. I mean, it was totally within the recommendations and the guidelines of the ophthalmologist for them to do this laser procedure for this person's retinopathy. And because the ophthalmologist billed a particular diagnosis code with the particular laser CPT code, the insurance denied it. They said, you can't bill. Yes, we'll cover that CPT code. Yes, we'll cover that diagnosis code, but we don't cover the two together. You can't, we don't pay for that CPT code with that diagnosis code. And the ophthalmologist was like, really? And of course, anytime any physician or doctor doesn't get paid, they just bill the patient. Like the knee-jerk reaction is just to bill the patient. So of course, the patient got the bill from the ophthalmologist, and it was like low thousands. I'm going to say it was like $1,300, and they contacted us, right? So that was the reason why we got involved. And so the problem is, it was lots of problems with medical policy, but one of the problems with medical policy is that it's highly inconsistent across carriers. So that particular carrier might have had an issue with that diagnosis code and that CPT code, but other carriers have no problems with that at all. Another specific example of that is for pulmonary function tests, or PFTs. You go into this almost looks like a telephone booth, and you breathe into it. It measures your lung volumes, and you use it for sort of the diagnosis and staging of COPD and asthma. And there are specifically for this one Blue Cross plan that we were looking for, they would, and it's a series of CPT codes. This one Blue Cross plan that we worked for only paid for 2 of the CPT codes, whereas other Blue Cross plans in the Blue Cross Association would pay for all 4. And it's like, well, why would only one Blue Cross plan pay for 2 and the other Blue Cross plans pay for 4? It was rather indiscriminate. And so if you happen to be on that one Blue Cross plan that only paid for the 2, you would get balance billed for the other 2 from the pulmonologist. So anyway, we went back, and you can go through the appeals process. And guess what? When you go through the appeals process, there's first level appeals. Guess what? Almost every single first level appeal gets denied. So we just do it because you got to do it. So nobody should ever stop after a first level appeal. That's a guaranteed denial. First level appeals shouldn't even exist, because it's just basically an automatic denial. Okay, then there's second level appeals. And there's third level appeals, okay? So you can do 3 levels of appeals, and the third level appeal even has to happen through arbitration outside of the insurance company itself. And so because we had expertise in the appeals process, then we could run through that. And all you have to do is provide the clinical documentation and have the ophthalmology medical director at the insurance company look at it, and they're like, yeah, that's actually standard of care. That's not weird. We should totally pay for that. And they did. So anyway, the next one was, we did gobs of this, right? Where this gentleman had prostate cancer and needed to have a prostatectomy, and his urologist, in-network urologist, originally scheduled him at a facility for his prostatectomy that the in-network allowed amount was going to be $75,000, and literally 2 miles down the highway at another in-network hospital with the same urologist. The urologist would do basically his surgeries at those 2 hospitals. It was $25,000. It was a third the cost. It was $50,000 less. And we're just like, look, you like Dr. Jones, you keep Dr. Jones. You don't have to switch from Dr. Jones. Let's just switch the facility to a different hospital. And Dr. Jones is like, okay, that's fine. I can't do it on Tuesday there, but I can do it on Thursday. And so literally, and we did this. It was a relatively, it was a holding company. And the holding company had 150 employees, and they were self-funded. So they were kind of smaller on the self-funded side, but they were the holding company for several much larger companies. They had a forklift company that had 3,000 employees. And so the CFO of the holding company would joke around and be like, yeah, just that one surgery alone paid for Compass for like the next 30 years. Okay. And then lastly, so that's an example of exit, right? So just exited the system, right? You just exited that particular hospital. We're like, look, we're just getting out of here. Optho was voice, and then gastroparesis was exit as well, because you just exited the existing gastroenterologist, right? We didn't try to up manage the gastroenterologist. We didn't complain to the gastroenterologist and try to get, him or he or she to change their treatment plan. We're just like, we're voting with our feet, and we're going to go to a different provider, because sometimes you just got to walk away and you got to go somewhere else. And then the last example is there was a gentleman who was an administrator of a make sure you guys are doing okay. You guys can still hear me okay? Write in the notes if you can. There was an administrator at also at a community college who unfortunately had to get cardiac cath and stents, and he was getting balance billed by the hospital for $15,000 incorrectly. And he was an older gentleman, and he was actually delaying his retirement because he thought he had to work longer to pay off this $15,000. And when we went back in, we identified the error that the hospital had been making. They basically had not been writing off the discount from the insurance company correctly. And so that 15 grand should have been written off because it was just part of the discount for being, in network with the insurance company. And like, he was able to retire sooner. So like these things literally, it was a huge deal. I mean, he'd been working for years, and he was like delaying his retirement by like over a year so he could pay off this extra $15,000. And so it's a huge financial ramifications here. Like, it's not just, healthcare is not just like quote unquote expensive. I mean, it dramatically impacts people's lives. He had bought like 20 acres out in the country, and he was going to put a single wide trailer on it for him and his wife. Like, that was his retirement dream, was to live in a single wide trailer out in the country. And he had been delaying that because of this $15,000 bill. Okay, so that's an exit of voice, right? You can't just walk away from that bill, right? So we had to use our voice to correct it. Okay, success 2. Third generation patient-centered medical homes, primary care. If you work in healthcare or health insurance, you have to know who Dr. Brent James is. I mean, this guy is a genius. If you want to go on YouTube or go on the internet and read about this gentleman, I mean, he's awesome. He's retired now, but he's awesome. So he led the effort in clinical quality at the entire Intermountain health system in Utah. Like, he and his colleagues out there are the reason why Intermountain, I mean, it's like in Utah, like nothing against Utah, but it's like, why in the world would healthcare in Utah be extraordinarily good? In large part, it's because of Dr. Brent James. So they created, Intermountain has hospitals, but then it also has outpatient clinics as well throughout the Salt Lake City area. And at those outpatient primary care clinics, they started out having these, chronic condition like nurses, so that not only would you talk to the doctor, but you talk to the nurse while you were there, and the nurse would like call you and check up on with you. So they would do a lot of that quote unquote disease management stuff, but it wasn't through the health insurance company. It was through the primary care clinic. And I'm like, okay, that's pretty cool. And then they added second generation, which is actually, they put behavioral health in each of the clinics as well. So they put therapists and counselors, because like a lot of our people with diabetes, they're depressed. And like the nurses weren't really qualified to help them with their depression. And the doctor was prescribing them the Prozac, but they needed more than that. And so they actually had then counselors, so that, at the end of the day, it's hard. There are cognitive challenges for people with depression. They have a hard time remembering things. They have a hard time remembering to take their medication, or if they took their medication. So you can literally like improve people's adherence to taking their pills if you can treat their depression effectively. So they embedded the behavioral health in the clinic. So you didn't have to go to two separate places. Like, it was all together. You can like see your doc first and then see your therapist right after, or vice versa. So that's second generation. And then they're like, people are still getting lost in the system, right? So it's almost like a mini Kaiser. Like, you stayed within Intermountain for your care, but even navigating the Intermountain healthcare system was too complicated for people. So they're like, we're going to add health system navigation to like help coordinate care between your cardiologist and your nephrologist and your appointments and all that sort of stuff, because they found that their patients were getting lost in the system. Even if they had the nurses talking to them about their medical condition, even if they were helping them with their depression, the patients were still getting lost in the system. And they needed somebody administratively to hold their hand, kind of like what we did at Compass within the Intermountain health system. Fascinating. Why in the world would Intermountain do this? Because Intermountain owns its own health insurance company, and they sell health insurance in Utah and Nevada and Idaho that's called Select Health. Aha. So Intermountain was collecting premium and was at risk. Amazing things happen when the folks who are providing the care actually take on risk as well. So that's why they put in the third generation patient-centered medical home. What happened as a result of the patient-centered medical home? Hospitalization down 22%. That is amazing. I mean, and it was only made possible because they ran their own health insurance company. With the typical fee-for-service, no-risk business model of a hospital, if you had a clinical solution that was going to reduce hospitalizations by 22%, like the hospital's CEO and CFO would be like, don't you dare reduce my hospitalizations by 22%. Like, that would be financial ruin for the hospital, right? So the point is not to, that's why you have to change the financial incentives, because of course the CFO and the CEO are not bad people, but as Charlie Munger says, incentives are superpowers. And so you have to change the you've heard me say this a gazillion times on A Healthcare Z. So that's why the people who provide care actually have to take on risk. That's why that's so important. That's why you have to do that. And you can call that value-based care. You can call it capitation. You can call it whatever you want. But the folks that are providing care, in my opinion, they got to take on some risk. Okay. ER visits down 11%, imaging down 11%. Dr. Brent James also did this within the inpatient setting as well, where they had Intermountain Healthcare is heavily protocol driven. In other words, they have ICU protocols, they've got surgery protocols, and they use that to decrease the variability of the care in the actual hospitals. Huge success, fantastic outcomes. How did they do this? They did this through the Institute for Health Delivery that Dr. Brent James started at Intermountain. And he said that, and all these other doctors and hospital systems would come to Intermountain to try to learn about how Dr. Brent James and his colleagues, how they did this. And he said the first thing that any hospital system needs to do is they need to create a quality improvement training course, because Dr. Brent James didn't come up with all these ideas. The frontline nurses and doctors and staff, they see this every day. They see the problems, but a lot of them don't know how to translate those problems that they're seeing into a system-wide solution, which is why they actually had to sort of train the frontline staff to think about, sort of like the Toyota production system, right? When the Toyota production system, when they see something faulty on the assembly line, then they ring a bell and all these engineers come in there and like, okay, what's going on? We got to get to the root cause of this problem, et cetera, et cetera. And so they had to train the staff on how to do that. Now, I would say that part of the secret sauce of Dr. Brent James is that he's a family practice doctor. Dr. Brent James is involved in the care of the entire person, not just the heart, not just the brains, not just the lungs. Dr. Brent James isn't only concerned about adults. Dr. Brent James isn't only concerned about kids. Dr. Brent James is not only concerned about women. He's concerned about all of them. And so it takes that holistic thinking, that system-wide we talk about whole person health, right? You can call that whatever you want. You can use the latest buzzword, whole person health, if you want. Like, it's called primary care, right? It's been around for forever. I guess you can't charge as much if you just call it primary care. But like, it's just primary care. It's been around for hundreds of years, okay? Number 3. Now, I have to talk about where I am currently at SimplePay Health. So obviously, full disclaimer, I'm the medical director of SimplePay Health. So success number 3 in plan design. Oh, let me go through the voice versus exit here. Did I do this here? Okay. Intermountain Health exited fee for service. Not totally, but for their health plan members at Select Health, they exited fee for service. Okay. And then they're interestingly, I would say that they're really their use of voice, because the Intermountain as a hospital system, they couldn't exit their patients. So interestingly, this is where the organization also had to use, it's basically, they didn't fire their patients, right? The hospital system could have exited the relationship with their patients and then just fired them. And they didn't do that. Instead, they used the primary care clinics and the behavioral health and the nurses to do outreach to the patients, to have a voice, to have a conversation, to do behavior modification with those people as well. So again, it wasn't just exiting fee for service. It wasn't just having that communication and that voice with their patients. It was a combination of the two. Again, the synergy of exit and voice. Okay, so now, what we're doing at SimplePay is it is a zero deductible copay only plan. So it is essentially exiting historical health insurance plan designs. Okay, so why is that? I've made a previous A Healthcare Z videos about this. Nobody understands them. Only 4% of plan members understand the 4 basic terms of deductible, copay, coinsurance, and out-of-pocket max. Like 4%, 1 out of 25 people actually understands the basic concepts surrounding how their health insurance works. So, okay, so do we just better educate them? Why don't we just throw out the plan design? Why don't we just exit the plan design and get rid of the deductible and just make it copays? Because what's a copay called? It's called the price that you pay. It's like when you go into a grocery store, it's the price. It's like what you pay, right? So you don't have to worry about this price transparency business, because you have price certainty, because the price for the patient is just the copay. And you can know that in advance, and you say it's going to be $30, and then it is $30, and you're done. That's called normal. It's not that hard. Okay, so that's number one. Number two is nobody can afford this stuff, right? The Federal Reserve did a survey that said that 30% of Americans couldn't even come up with $400 in the case of an emergency. Well, shoot, when you've got an average individual deductible of $1,000 to $2,000, I mean, upwards of 60, 70, 80% of Americans, they can't afford their deductible. So it's essentially saying that they don't have insurance because it's inadequate, or they're underinsured, or whatever sort of modern term you want to use these days. So the point is that if you actually instead of front loading the cost share with the deductible with gobs of cost share up front, and then the insurance kicks in, why not just spread the cost share out more evenly with copays over time? And you can actually keep the actuarial value of the plan the same. You want to have a 70 or an 80% actuarial value plan? You can totally do that. Okay. Then number two is that the copays are not the same, right? Because it's okay, well, if doctors and hospitals are different, why would you give them all the same price? Like for everything else, we don't have the same price for if you're getting your car repaired, it costs one price at one place and one price at another place. You're getting a loaf of bread or fruit. It costs one thing at one place. It costs something else at somewhere else, right? So this idea of price variability, depending upon where you go, that makes sense. People kind of get that. And so we actually structure the copays so that the higher quality physicians, where we want people to go to, and the higher quality facilities in the areas that are centers of excellence, they've got lower dollar copays to financially align the patients with where the employer wants them to go. And then you have higher dollar copays for the lower quality places that have higher infection rates and higher readmission rates and are not centers of excellence, because you don't want them to go in that place. So that's pretty easy to understand that, okay, the price is just the copay, and then the price is different depending upon where you go. And then the final thing too is, and this came from a lot of our experience at Compass, is that, look, at the end of the day, the docs and the hospitals, they still screw up the billing. God bless them, they're trying. But instead of having the docs and hospitals bill the patient at all, just completely take them out of the picture. This is exit, right? Docs and hospitals, you are no longer in the business of collecting money from patients. And I think everybody's better. Listen, doctors and hospitals don't want to collect money from patients. And the patients don't want to deal with the errors from all this collection from the hospital system and the doctor. So instead, all the SimplePay folks do, they just get one monthly statement, just like a credit card. When you go and you pay for your groceries at the grocery store, you just get a statement. Like, you don't pay cash at the grocery store and get your credit card statement. Like, you just get your credit card statement. And so like people are like, okay, that's kind of normal. I go to a place, I use the card and then I'll get a statement later, right? That's kind of normal. And so you get the statement, and we actually do it at zero interest. So it's not like it's an interest bearing, sort of, credit card type account. The fact that it's a 1 monthly statement is how it's similar, but we don't do it in any sort of interest at all. And so guess what? People like understand this, right? So we've essentially like exited the plan design, and then we haven't exited the network, right? So some people use like narrow networks or whatever. So we haven't exited the network, but we've essentially expressed voice within the network in terms of preference of where we want plan members to go. And so what does that do? Huge affordability benefit. So now when employers, and it tends to be a lot of companies that have lower wage employees, hourly workers, they still give them major medical, but they can actually afford. Because like, even if you have like a $400 copay, you don't have to pay it out all at once. You can pay it out over time, just like you do, on a credit card, except it's at 0% financing. So it actually allows you to have affordability with your care so that you don't delay care or not seek care, so that you can actually get the care that you need, so that you can nip a smaller problem in the bud when it's a $500 problem, as opposed to when it's a $50,000 problem. And then it alleviates the entire price transparency boondoggle, because it's like, okay, the price is the copay. Like, don't even bother. Like, okay. And then you get billing clarity and ease. Like, who understands their bills and their EOBs today? Like, nobody understands that. Like, you've heard me say this before. Like, the CEO of a major health insurance company in America even admitted that the EOB was the most worthless piece of paper ever created. So here it's like, okay, service, copay, service, copay, service, copay. Like, it's not that hard. It's just like on your credit card statement that you get today. So what happened? Well, look at what happens when you do the copay differentials in a way that people can actually understand in advance. So before we put in SimplePay, about 23% of the claim spend was going to high quality providers. And then after you put in the SimplePay plan, like 86% of the claim spend ends up going to these high quality providers. So it is been a fantastic affordability and quality maximization tool for employers. So I just want to share that as well. So like, it's been great. Next up. Success number 4. This is the last example of success. Value-based care. Okay. So again, value-based care means different things to different people. Specifically, what it means here is the healthcare providers taking on risk in the form of capitation. And Ochsner Health in New Orleans, and they've expanded now, they're in Alabama and Mississippi as well, is a fantastic example of this, where they took on risk for their Medicare Advantage patients. This is pre-COVID that they did this, but they still had regular traditional Medicare patients coming into Ochsner as well. Obviously, it's a huge hospital system in the South. Now, for their Medicare Advantage patients where they were taking on risks, this is what they did for them. They did in-home visits. They did outpatient case management. They did post-acute care management. So post-acute care is going to be things like if a person goes to a SNF, a skilled nursing facility, if a person goes to acute rehab, if a person goes to a long-term acute care hospital, or what's referred to as an LTAC, like the hospital, oftentimes when the hospital sends somebody to SNF or LTAC or rehab, they're like, we're done. We discharged you. See ya. If you get readmitted, you get readmitted. Like, no. Like, we need to be involved because we're at risk here. We need to be involved with you. Even if you're not within the 4 walls of this hospital, we still need to help out and be involved and know what's going on and coordinate. They pushed their care out of the hospital and into the primary care clinics, into the community. And then the last piece that got cut off here is they did repeated health risk assessments. So they gathered lots of data, not just from the electronic medical record, but they were actually gathering data from the patients themselves and like survey questions from the patients themselves in terms of their mood and their living situation, because all these things in the biopsychosocial model of disease, they impact your care and your health. And so they incorporated all of that as well. Now, they did all that and they paid their doctors differently. they're like, all this is fancy stuff on the previous slide, but unless we pay our doctors differently, and unless the incentive of the doctor in their interactions with their patients is different, it will not work. So they changed it. No more fee for service, and they got rid of the RVUs. I think they might have still had some RVUs for the proceduralists, but not for the primary care docs. So primary care physicians were paid based on the performance of their patient panel, not on how many visits they got done and how many RVUs they billed. For their specialists, their compensation was based upon things like decreased variability. So one of the specific examples was around like C-sections for their OBGYNs, where they're like, okay, they would risk adjust it for the clinical situation of the mom. And they're like, look, you got some OBGYNs that are doing gobs of C-sections over here, and we got others that are not. Like, you folks that are doing gobs of C-sections, like, why are you an outlier? Is there a clinical justification for that? And if not, then we need to work with you around changing your practice pattern to become less of an outlier. And also, frankly, around unwarranted care. So this is where the measure of quality, so this is where the surgeons and the proceduralists were not financially incentivized to do more. In fact, they were actually financially penalized if they did unwarranted care, so they had to like monitor them more closely, be like, look, if you're doing a scope here or a stress test here, or you're cathing somebody here, and it's like not clinically warranted, then that's going to impact your pay. All right. They did gobs of data analytics work. They had a call center because they were doing all these calls out to the patients. So that's one of the keys here, is that through the doctor pay and through all those activities on the previous slide that I showed you there, the key to quote unquote value-based care is it's not in the hospital. It is outside of the hospital. The whole idea, and that's really what hospitals like to call themselves, health systems. Arguably, the vast majority of their health system work should happen outside of the quote unquote hospital. It should happen in the system, not in the hospital. And like a lot of these more advanced places like Geisinger, they look at a hospitalization as a failure. They don't look at it as a revenue opportunity. They're like, because we want to push, listen, not being hospitalized doesn't mean you're not getting care. It just means you're getting care in the community as an outpatient, not as an inpatient. And that's what's called preferable. Okay, so results. They actually looked at this. They said, okay, we're going to look at 30,000 patients that are Medicare Advantage patients, and we're going to look at 30,000 traditional Medicare fee-for-service patients. The Medicare Advantage, and again, risk adjusted for, complexity, age, all that good stuff. The Medicare Advantage patients cost $100 million less per year. Now, with your typical Medicare Advantage, sort of amount that they're paying out in claims, et cetera, it's about $18,000 per beneficiary per year. So that means that the traditional Medicare folks were $540 million of government spend, whereas or healthcare costs, I should say, whereas the Medicare Advantage were $440 million of healthcare spend. So it is a 19% decrease in healthcare spending when you got healthcare outside of the four walls of the hospital and you change the way that the doctors were paid. Huge success. Okay, so again, this is meant to be a discussion of success because change is absolutely possible. It has happened and it will continue to happen. And one of the frameworks that helps foster this change, and this is the summary slide here, is that the exit and voice act synergistically to improve things in healthcare for patients. Exit and voice work synergistically to improve things for patients in healthcare. Why? Because people and organizations are more willing to listen to the voice if they're faced with the threat of exit. So we say, oh, well, we talk to management or, et cetera, et cetera. We expressed our voice. That's great. It also needs to be accompanied with exit. This also includes things like, so let's just talk about like physician burnout. Like physicians are like, oh, I feel so burnt out. I'm going to complain to the administrators of the hospital. Like, listen, some of you just need to leave, right? And that's the smartest thing to do. Like exit is synergistic with voice. exit actually improves the effectiveness of voice. It's not shouting louder. It's not shouting more vocally. It's not shouting more frequently. It's not shouting more articulately. It's having the leverage of the exit that is super important. So because pain causes change. That's one of my favorite quotes from Stephen Covey. Pain causes change. And it's the pain of exit that causes change. Now, for all of you watching, what can we do in our efforts as brokers and benefits consultants in pharma, med device, who work in hospital systems, who work as physicians, who work in employers in HR? What can we do when we think about things that we can do? What are things within healthcare and health insurance that we can just exit, where we're like, maybe we just need to just ditch X completely? Like, forget about trying to make it better. Let's just ditch it. And obviously, one of the things that I've talked about time and time again is that, like, fee-for-service primary care just needs to be ditched. Like, it just needs to be exited. And that is within the capability of every single employer to use direct primary care, on-site clinic, near-site clinic, like what have you. Like, every employer can make that happen. And it doesn't even have to be there. There's other ways that you can just take a problem within healthcare and just exit it. I'm not saying exit the entire healthcare system, but there are things where you as a plan, or you as a patient, or you as a hospital system, you can just exit, and that will dramatically increase the leverage and the effectiveness at your voice at the same time. So, all that being said, if you would like to subscribe to my A Healthcare Z email newsletter, I send out a video email newsletter. You can email me at ericb@ahealthcarez.com. If you would like to subscribe to my YouTube channel, just go to YouTube and type in A Healthcare Z. You can subscribe there. Just connect with me on LinkedIn, then you'll get my videos popping up on your feed on LinkedIn as well. Now, you've put in various questions over the course of our time together. So I'm actually going to go through and look at them. So thank you for putting in all these comments and questions, and I'm going to look at them as we conclude here. So Dennis from LinkedIn, thank you for your comment here. There is a paradox with cost and quality. Most often, the lowest cost facilities are the highest quality. WellNet provides similar concierge services through your care advocates to help members navigate the complex health system, including finding the highest value. Yeah, that's great. Fantastic. Thank you for that comment. And I'll add that one of the direct results from our Compass navigation service is that TPAs and carriers then created their own navigation services. And I related in a previous video, I wrote about it in my book, that one of the major Blues plans invited us, our CEO and myself, into there to meet with their president, their head of strategy, and their head of operations, their head of marketing. And they, were, shooting us gobs of questions about our navigation services. And then they said to us, okay, it's fascinating what you're doing. And I'm like, okay, this is our huge opportunity. They're going to want to partner with us. And they said, we're just going to copy what you do and just provide navigation services ourselves. And then they walked us out of the building. So, and listen, at the end of the day, like, it's a free country, like, that's okay. And the point is that, arguably they would have never done that had we not been the thorn in their side, getting their customers interested in what we were doing. And listen, we had, we've come across employees at other companies that use this carrier, and they have the navigation services like through that carrier. And it was like totally helpful for them. And so they were able to get navigation help, frankly, because we irritated the carrier to actually make a change. So again, pain causes change. LinkedIn user, how are they able to balance bill when the hospital is in network? Happens all the time. Just because they shouldn't do it doesn't mean that they don't. So there's a lot of hospital systems that do what's called shotgun billing, where they'll bill the insurance company and the member at the same time, and they'll bill them with full bill charges because the insurance company hasn't even paid yet, so they don't even know what the discount's going to be. So, in fact, where I did my residency at Johns Hopkins, they did that. My wife had an ER visit where they billed her insurance and her at the same time. She's an employee there. They billed her and the insurance at the same time for $5,000. And she's like, what you, I'm like, well, don't pay that $5,000. I mean, they haven't even billed your insurance company yet. It hasn't been adjudicated. There's been no discount applied. She only got the bill like a week after her ER visit. So it's actually very common for hospitals to bill members for full billed charges. I'm not saying it's right, but it definitely happens. All right. Thank you so much for your questions here and your comments. Great. I'm just reading through them. Thank you so much. So a couple comments here about using HSAs and reference-based pricing. So I would argue that reference-based pricing is also an example of exit. You've essentially exited the entire PPO discount in quotations framework, which for some parts of the country and for some employers makes sense. And really the challenge with a lot of RBP plans is that there are still places in the country and there are still hospital systems where if you don't have, in RBP, you don't have a network and the hospital has absolutely no interest in negotiating, 200%, 300%, 150% of Medicare. Like they have no interest in playing that game. And so they will just go after you for full bill charges, send you to collections for full bill charges. If you're going in for an elective surgery, you need to pay full bill charges prior to your elective surgery. It's unfortunate. It's just, in places like Montana, they were able to sort of, arm twist the hospitals to agree to 150%, 200% of Medicare. Some hospitals will go along with it, but not all of them do. So I think it absolutely is an exit solution for some employers in some parts of the country, which, healthcare is so big, you can still have a viable business and a viable solution in a very small niche of healthcare, just because healthcare is, over $3 trillion. Okay. Looking through. Thank you. So got a question here from Ryan. Thank you. Health systems with success in taking risk in MA population often struggle to offer the same services to their commercial patients who have different needs. If they're not Kaiser committed to the segment, are they better off taking an exit? So the short answer is yes. It's a great question, Ryan. So interestingly, right, if you go back to, I won't do it now, but if you go back to the slide where I talk about all the services that Ochsner provided as outpatients, like ideally, all of their patients would benefit from that approach. But at the end of the day, Ochsner is not financially compensated in a way to do that. They're not paid that way. And so they don't operate. They treat their patients differently. If you're a Medicare Advantage, and a lot of places, like if you're same thing with Intermountain, if you're a select health patient, like it's done differently than if you're, somebody else who's, because you could like not use their clinics, et cetera, and you just go fee for service to have your knee replacement at Intermountain. And it's like, it's different. And so that's where, Rome's not built in a day, but really that's where over time, more and more of that reimbursement to the hospital system has to take the form of the risk, such that the risk mitigation approaches to their care is really standardized across all of their patients. Today, that's just not the case. It's not. We're not there. And so it is beholden to all of us on this call and on this training session to keep pushing, because just like everything, like it has a tipping point, right? It's that the percent of revenue that comes from risk for a hospital system is right now it's below the tipping point, but we have to keep pushing because it eventually will get beyond the tipping point such that everything will flow over to that risk-based compensation. We're just not there yet. I'm optimistic. I think we will get there, but we're definitely not there yet, to your point. And with that, we are coming up on time. So I want to thank you for giving me your time and attention. It's been a fantastic opportunity to speak with all of you today, and I hope you have a great rest of your day and a great week. Bye now.